Good morning. Thank you all for being here. Thank you, Sarah, Rupert, other Sarah, Sam, for organizing an incredible week. It really has been such a treat. And it's my honor to be here and speaking with you all. As a clinician researcher, I find myself drawn to the subjective. And to me, when we think of our patients, we're hearing about their highly subjective experiences, their experiences of themselves. And to me, this is the essence of the work that we do, not a confound or an uncomfortable artifact. And that's the perspective I want us to take as I walk through some of the data from my recent publication. This is looking at the subjective effects of dextromethorphan and psilocybin in a model of healthy volunteers. And I hope in this process we can also have a broader conversation, just thinking about durability when we approach dissociative therapies. I received salary support from the Johns Hopkins Center for Psychedelic and Consciousness Research and private funders. I have no commercial interest to report and want to emphasize that the findings here are experimental uses of psilocybin, dextromethorphan. These are not recommendations for clinical or recreational use. Several years ago, I had a published exchange with British researchers Mark Horowitz and Joanna Moncrief. Mark and Joanna have been famously critical of the medicalization of psychiatry and were quite critical of esketamine. And it was a really enlightening exchange for me, even if it was short. And there were five hard questions. There were five hard questions that came out of that. For me, one, how do we distinguish drug-induced euphoria, relaxation, or other transient disruptions in depressive states from a desirable antidepressant effect? Two, we talked about this yesterday, do research trials confirm a clinically relevant effect when nonspecific effects are accounted for? Three, are we underestimating the risks of repeated medication administration for short-term relief? And if so, it wouldn't be the first time. What is maintenance treatment supposed to look like? How much, how often, for how long? And five, are we overestimating our own abilities to mitigate the risks involved? And if that's the case, what could go wrong? These questions still concern me, are in the backdrop of a lot of what I think about, and have informed a lot of my work focusing on more durable models of dissociative therapies. Part of that journey for me took me to the Johns Hopkins Psychedelic Center, where I got to work with folks like Bill Richards and the late Roland Griffiths. For me, this was a place where I could ask some of these hard questions and also think about different possibilities for psychopharmacology. Steve already went into this yesterday, but as a quick overview, these were drugs, a class of drugs that were named for their mind-manifesting properties, producing context-dependent changes in thought, mood, and perception that are otherwise rarely experienced, except for maybe states of dreaming or religious exaltation. They've been associated with rapid symptom improvement across different trials of different indications that exist beyond the period of acute drug effects. And for me, just as important, if not more important, they've been associated with enduring well-being and psychological benefit. For example, positive changes in attitudes towards life, towards self, relationships, behavior, and spirituality. And for me, at least, this was a lot of what brought me to psychiatry in the first place. Classic psychedelics, as they're defined, act primarily on serotonin 2A receptors. Other drugs like ketamine and MDMA are variably considered psychedelics because of different mechanisms of action. That's a fierce debate that I'm not going to get into, but just in terms of thinking about these different drugs. So why am I talking about cough syrup? Dextromethorphan, or DXM, as it's often abbreviated, is the D isomer of the opioid analgesic methorphan. It was first described synthesized in 1947. Unlike methorphan and the L isomer, it's thought to possess minimal activity at mu opioid receptors. It was approved by the FDA in 1958 as a non-prescription replacement for codeine-based cough syrups, under the brand name Romular. Since then, we've seen other formulations like Delsum, Robitussin DM, and within these formulations, the max daily dose is 120 milligrams every 24 hours. It's been repurposed over the years as well as a compounded formulation with quinidine for pseudobulbar affect, and more recently, in August of 2022, was approved by the FDA in combination with bupropion as a rapid-acting oral antidepressant. Importantly, the antidepressant dose here is 45 to 90 milligrams daily. So I think that dextromethorphan can be a really useful model in thinking about ketamine and how it works, and there are a couple of reasons why I think this is the case. First of all, there's a lot of overlap in their receptor activities. We know that both ketamine and dextromethorphan are non-competitive NMDA receptor antagonists. They both bind at the PCP site of the receptor. There are some differences. For example, dextromethorphan is thought to have greater potency at the NMDA receptor, is thought to have greater function as an inhibitor of the serotonin transporter. There's some activity on nicotinic acetylcholine receptors, some differences there. There are also similar functional properties. There haven't really been too many head-to-head studies, but we get some clues, for example, from this clinical trial of both ketamine and dextromethorphan crossed over in patients with neuropathic pain, and we see that they have similar properties in terms of attenuating pain hypersensitivity. And they're both dissociative hallucinogens. So when we think about this pharmacological class, these are really characterized by their unique subjective effects, marked by a sense of distance or separation from one sense of self or one sense of reality. Thank you to Marco for touching on some of this yesterday, but this is data that I've plotted from two different studies. It's a comparison of the 5D ASC, a scale used to measure psychedelic and non-psychedelic states of consciousness. And you can see how closely these lines track. And you can see especially here for the subscale of disembodiment, how similar these properties are, really that characteristic feature, dose-dependent feature of these drugs. So why are we studying dextromethorphan with psilocybin? So the reason for this is interesting. A lot of this actually has to do not with dextromethorphan as a potential therapeutic agent, but rather our lab's interest in finding an effective positive control for psilocybin and a lot of the psilocybin studies that were being done. So this is some of the foundational work from Chad Reisig back in 2012. And it was a dose-response study of different doses of dextromethorphan. They looked at doses ranging from 100 to 800 milligrams per 70 kilograms in 12 volunteers, double-blind conditions. And he saw that the peak effects occurred at 2 to 4 hours, closer to 2 hours. The duration was about 6 hours. And you can see how this more closely resembles the trajectory of the psilocybin molecule and those effects compared to, for example, ketamine. The dose of 400 milligrams was identified as one that was highly tolerable and also produced a similar profile of subjective effects as those seen with psilocybin. So psilocybin wasn't studied in this particular trial, but they did compare across these different studies. And interestingly enough, participants were also blinded as far as their condition. So they were asked to guess what they thought they had received from 18 different drug classes. 0% guessed they'd received a dissociative drug, even though 58% had previous experiences with dextromethorphan. 92% guessed that they'd received a classic psychedelic and were fairly confident in these guesses too. They rated the similarity to a classic psychedelic as 93 out of 100 on a visual analog scale. So that really sets the stage for my analysis and the trial that I'll be talking to you about today. So this was started in 2014, an exploration of the effects of hallucinogens, particularly psilocybin and dextromethorphan in healthy volunteers. These are the methods that were used for the study. Recruited 20 hallucinogen-experienced adults, about even split of female and male. And It was required that participants had experiences of both classic psychedelic and dissociative use. This was thought to help with tolerability and also thought to help standardize for previous histories of use. For example, someone who hadn't used one or the other might be expected to have very different effects. We did screen for substance use disorders and made sure that participants were medically and psychiatrically healthy. And all subjects went through 5 dosing sessions where they received a different drug during each experimental session. So they received 3 doses of psilocybin, 10, 20, and 30 milligrams. Dextromethorphan, 400 milligrams. This dose was selected based on some of that preliminary data I was telling you about, and placebo. So this occurred under double-blind, randomized conditions. It was a within subjects crossover design. And the sequence of conditions was also counterbalanced across participants. We really wanted to equally distribute any possible carryover effects, sequence effects. And participants were informed, as before, that they could receive placebo or doses of 38 different psychoactive drugs from 14 different classes. So you can see that there was a lot of experimental manipulation here. We really wanted to try to the extent possible to control for expectancy. The support in these trials was that's typical of psychedelic research studies. There was a lot of emphasis on set and setting. Sessions took place in a living room-like environment. There was significant therapeutic contact, 8 hours of preparation, dosing support, integration, and follow-up. You can see that mapped out down here with the prep and alternating dosing and integration sessions. There was about 1 to 2 days between dosing and integration, and about a week between consecutive dosing sessions. One difference is that compared to therapeutic trials, there was more measurement throughout these sessions, especially, for example, some of the neurocognitive assessments that were administered in previous analyses, previous reports. So just to quickly recap some of those previous analyses, these looked at a variety of effects across time points. We're really focused on the acute effects of these drugs, and dextromethorphan was found to elicit similar subjective profile as moderate and high doses of psilocybin. Some unique differences. Psilocybin had the most pronounced effects overall in dose-dependent fashion. This includes things like greater insight, positive mood, more mystical experiences, and so on. Some things that stood out for dextromethorphan was associated with greater disembodiment, physical discomfort, so things like nausea, vomiting, dizziness, more impairment of balance, episodic memory, and executive control, and also was more likely to be reported as less real compared to everyday consciousness compared to psilocybin, which was more likely to be reported as more real. That takes us to my analysis, and here I was really focused on the persisting effects of these drugs. In other words, the potential for durable psychological change existing beyond that acute period of effects, and to see how these were influenced by different subjective ratings of acute drug experience. So we looked at the Persisting Effects Questionnaire, the PEQ. This is 145 items assessing changes in attitudes towards life, attitudes towards self. I talked about these 6 domains earlier. Each of these domains were divided into positive and negative subscales. And so in other words, you could come up with a score for looking at positive changes in attitudes towards life and negative changes in attitudes towards life. Items were rated 0 to 5, and 5 was most extreme change or an extreme effect. These were measured after about 1 week, just before the next dosing session. Subjective ratings, I used 4 items that have been used across the studies of psilocybin, looking at the degree to which dosing sessions were experienced as personally meaningful, spiritually significant, psychologically challenging, and psychologically insightful. These items were ranked 1 through 8, 8, for example, being the single most personally meaningful experience of my life. These were measured at the end of session, again at 1 week. So quickly to go over some of the masking data. Here we can see participant guesses across the drug conditions. As far as guessing the correct drug class, we can see these guesses were fairly high, especially for psilocybin. They're somewhat lower for dextromethorphan, close to 60%, For this condition, participants were also likely to guess a classic psychedelic, an entactogen, something like MDMA, sedative, so on. When we also added, could they guess the correct drug within the drug class, you can see that those rates go down substantially in the range of 35 to 65%. And finally, we could uniquely look at for psilocybin if they were able to guess the correct dose range. So for this item, these rates are even lower, 15 to 30%. And importantly, participants guessed in both directions. They would sometimes guess too low, sometimes guess too high. So it's not perfect by any means, but there is a considerable amount of uncertainty here. And I think this trial really stands out in terms of some of the effort taken towards controlling for expectancy. As far as subjective ratings of drug experience, those are shown here. We use linear mixed models to look at these effects and the Tukey method for post hoc testing. So this is a plot of each of those categories. And you can see on the x-axis down below, we have each drug condition. The light gray bar is the score at the end of session. The dark gray is 1 week afterwards. Really broadly here, we saw significant changes from placebo. And what stood out for dextromethorphan is that these sessions were likely to be experienced as personally meaningful, more spiritually significant, and more psychologically challenging than placebo. This difference didn't stand out for ratings of psychological insight. As far as persisting effects, we used a similar model. And here I've pulled a table from the supplement just to show a little bit more detail. These are the Cohen's DZ within subject effect sizes for each of these comparisons for active drug condition to placebo. There are a lot of numbers here, but I'll walk you through it. The green highlights the increases over placebo that remain significant after correcting for multiple comparisons. And we saw a really nice dose response for psilocybin. You can see how those effect sizes trend up by dose. And this is even given some of the uncertainty we talked about earlier when it came to guesses. Especially for the two highest doses of psilocybin, we saw that there were significant changes across the board for every single positive domain assessed. For dextromethorphan, we found significant results for just two of the domains. Dextromethorphan did result in positive changes in attitudes towards life and spirituality at 1 week. When we look at these effect sizes for some of the other positive domains, these are fairly sized. These are medium relationships, and it looks like there is signal here that just didn't survive correction. And finally, how do drug experience predict persisting effects? So here I've put the Pearson correlation coefficients for these different ratings. And for this particular analysis, we were really focused on relationships. So these were all planned comparisons. We didn't correct for multiplicity. And these are the numbers that we saw. The bold values are those that were statistically significant. And again, to break this down and walk you through it, for the psilocybin 20 milligram dose, we see really remarkable relationships between these ratings of the drug experience, of drug administration, and positive effects at 1 week. These are generally large effects that we're seeing. For the 30 milligram dose, we actually see none of these relationships, which was shocking to me at first. And then when I looked at the data a little bit more closely, we get a sort of ceiling effect. When some of these values are clustering towards their maximum possibles, it makes it difficult to see a meaningful regression. And then finally, for dextromethorphan, what stood out was ratings of the experience as personally meaningful. For volunteers, their experience of the session as meaningful contributed to positive changes in attitudes towards life, was associated with positive changes in attitudes towards self, mood, relationship, and spirituality. So again, what does it mean for an experience to be personally meaningful? This isn't something we closely assessed. We had some limited qualitative data, but volunteers said things like they had a profound reboot of physical and mental buildup, a lot of integration and resolution, experiencing pure emptiness of form, feeling free to express oneself and explore their mind, felt a freedom in navigation of my mind, felt the ability to accept what was happening without understanding it. I think there's still a lot for us to learn here about the effects that might be valuable, that might be predictive of those subsequent changes. And then finally, as a discussion, just quickly recapping 3 key findings. The acute experiences of psilocybin were rated as personally meaningful, spiritually significant, psychologically challenging, and insightful compared to placebo. Dextromethorphan compared similarly, except for ratings of the experience as psychologically insightful. Medium and high doses of psilocybin contributed to positive changes in attitudes towards life. All of these domains. Dextromethorphan seemed capable of similar effects when used under the same experimental conditions. Ratings of acute drug experience predicted positive changes at 1 week, most clearly for that 20 milligram dose of psilocybin. For dextromethorphan, ratings as personally meaningful were predictive of enduring psychological changes. So there are several key limitations to this study. One, I do believe that these experimental conditions at Hopkins have been optimized for psilocybin, and it may be that different conditions would favor dissociatives. As far as measurements of acute drug experience, these were quite limited too. I think it was important to not be so narrow as things like the CADS or the MEQ, which are limited as constructs. At the same time, there's room for a lot more precision, and I think we're still figuring out what that scale, what that instrument would look like. And then, of course, translating these findings to clinical hallucinogen-naive populations. That's something that's hard to say, that's hard to extrapolate, of course. As far as some of the positive effects we're seeing, I could imagine those going either way. We have literature that suggests they could go either way. I feel fairly confident that the negative effects would increase in hallucinogen-naive populations. So that's also something to keep in mind. And finally, that takes us back to our question about what are the optimal conditions for dissociative use. This is something that there's still room for ongoing conversation. But just drawing from this experience, this experiment, it looks like it could be possible to replicate some of the similar enduring effects when using similar conditions experimentally. So this includes things like the preparation, the attention to making meaning, the focus on psychological growth that we see with psychedelic research trials. And within that context, optimization could look really different. Rather than focusing on repeated drug administration or adjunctive medication, we may be paying attention to things like encouraging more contact with inner experiences, what it means to work through those, what psychological growth looks like. And of course, what's true for psilocybin and classic psychedelics may not be true for dissociatives. There's still a lot that we're learning here, and we are seeing lots of models of ketamine use, therapeutic ketamine use that we can learn from, where there are varying degrees of attention to experience. There are different ways of combining drug and psychological support. Some of this we talked about yesterday. And there's still a lot to learn about what questions we need to be asking about patient experiences. And this is some great work from our colleagues in the Netherlands who have looked at some of this qualitative data, which I think can inform our measurement. For example, Joost writes in this trial of oral esketamine for depression, he observed several participants noticing a detachment or interruption of negativity, hopelessness, and despair. Robert spoke about this yesterday too. This transient absence of incessant negative thoughts was associated with an enlarged space, an openness to other thoughts, ideas, and emotions. Paradoxically, as participants described becoming more detached from negative emotions, they also described having more room for emotions, both positive and negative. As they became more in touch with their own feelings and needs, some participants felt less self-critical. So therapeutically, there's a lot to work with there. And I think as a field, too, we have a lot to work with. There are clues that are coming from disciplines, from different disciplines, different directions of research. And it's hard to say at this point if the ship has already sailed, if things are too far gone, or if we still have a chance to pause, to think, and to together build something sturdy. Thank you.
Lovely talk. Thank you very much. Can I ask a question?
Of course, yeah.
So if dextromethorphan and psilocybin, broadly similar, if I understood this correctly, would that be either evidence that the main part of the effects were non-specific, or could it be that their mechanism of action is similar?
I think there is some similar mechanistic activity. People have written about converging pathways of glutamatergic involved neuroplasticity. That's something I don't know a whole lot about personally. Um, as far as the effects in this trial, I do think we see psilocybin being favored in some of the measures. I think, especially when we see that dose-dependent effect of psilocybin, I think that actually supports a drug-specific effect. It's hard to kind of distinguish that between dextromethorphan and psilocybin, but I do think we see some evidence for drug-specific effects here.
And how does this work inform your thinking about dextromethorphan as an active placebo?
I think for therapeutic trials that, we talked about this yesterday with Jerry, we're going to limit a lot of the ability, even more so, to see differences between different drugs that are being investigated. I think dextromethorphan, I would imagine, at higher doses that more closely resemble ketamine are going to have therapeutic effects. So I don't know if those are going to be useful comparisons as we try to optimize different drugs for clinical development.
Yeah. Okay. Other questions?
Just two quick questions. The first is, did you look at 2D6 genotypes for people getting dextromethorphan, given the variations in metabolism of the drug?
Yeah,
Secondly, just to add on, sorry, first question was about 2D6 metabolism of dextromethorphan and whether you looked at genotypes in relation to experiences. And the second is, given the sort of comparable kind of subjective experiences people had, why is it that we think about dextromethorphan as something that's liable to abuse and problematic dependency for people who take high doses, where we don't tend to think about that for psilocybin? Is that availability of the drug? Is it something about, or can you see anything in what people report about the experience that might speak to that abuse liability?
Yeah, those are great questions, and some of that has been engaged in some of these previous reports. In the first paper, Teresa Carbonera, who was a postdoc at the time, did look at 2D6 and didn't find any differences in metabolism. I don't think she looked at correlations with subjective experience, but did account for that. There is another paper, too, thinking about the addiction liability and looking at abuse liability parameters for these drugs. And psilocybin was actually more likely to be used again in ratings of using again within 1 month. I think 75 to 80% said yes to psilocybin as opposed to 25% for dextromethorphan. So there is a substantial difference in user preference there. I think they're potentially very different experiences. I briefly cited that data on the experience of things feeling more real versus less real. I wonder if different features like that could account for how people have different experiences. I do think psilocybin tends to be more psychologically challenging, too. I think people are more likely to have these difficult encounters with their sense of self in ways that wouldn't lend themselves to everyday use in many people. And at the same time, I think there are people who abuse psilocybin. That's something that we do need to think about as this field grows and expands. Thank you.
Jerry?
Great job, Dave. Great job. It's really interesting to see this type of work. But did I look at the numbers right? So the mean use of psilocybin was 70?
They were very high. Yeah, I don't remember.
These are like real experienced people. And it was much lower for dextromethorphan, right?
Yes. Yeah.
So you did say, and it's one of the limitations, but it's, in my mind, a big limitation. This favored psilocybin preferring people dramatically.
Yeah.
So, I mean, that's one of the big concerns here. And I think that's, for the field, we have to be careful of that. How much people want psilocybin. They travel from all over the countries to get it, and they expect it to work. And if they're not getting what they're expecting, you're diminishing some of that effect. So
Yeah.
It's just a concern. It's great. This is good to have all the data, but it is a limitation.
Yeah, of course. Are you kidding me? Coming to Johns Hopkins, wanting to do a psilocybin session for a trial there, I think that has huge effects. But I also think that doesn't take away from some of the dose dependency that we see for
Exactly.
psilocybin.
No, I agree.
Great. Thank you very much indeed, David.